An overview of retinopathy of prematurity by Dr. Akash Patel. There are many reasons why children can go blind, including retinopathy of prematurity or ROP. What we need to understand is that while little can be done to prevent the occurrence of the other causes, blindness due to ROP is largely preventable if detected on time. The key word here is detection on time. Even in the Western world, with high resources and a reasonably high doctor is to patient ratio, ROP forms the largest cause of infant blindness. In India, 500,000 premature babies are born every year. Even if we assume that 50% of them survive, with the Herculean efforts of our neonatologists and pediatricians, every hour 3 babies require treatment to prevent blindness due to ROP. With very few retinal specialists and even fewer surgeons who are trained in pediatric retinal work, the question becomes, how do we meet the challenge? Starting to understand the basics of the eye. The retina is the light-sensitive tissue in the back portion of the eye, which is equivalent to the film of the camera. It captures the images and sends them to the brain. The retinal blood vessels grow from the center towards the retinal periphery. This process begins at the 4th month of gestation and is completed just after birth. This normal retinal development takes place in term babies who are born with a normal birth weight. In premature babies with low birth weight, these blood vessels stop earlier and begin to develop ROP with the growth of abnormal blood vessels, which are fragile, leaky, and tend to bleed. This blood can lead to the formation of scar tissue, eventually detaching the retina from its normal position. This is when the child loses vision permanently. More premature the baby and lower the birth weight, greater is the amount of underdeveloped retina and higher the probability of developing ROP. Also, ROP is seen in higher frequency in the sicker and weaker babies. More posterior the location of the disease in the retina, greater is its severity. This is described in terms of zones, with disease in zone 1 being the most severe. The disease goes through 5 stages. It begins as a simple line which demarcates the normal from the immature retina, proceeding through the stage of an elevated ridge. With advancing disease, these fragile abnormal blood vessels grow towards the center of the eye. Other signs indicating a severe form of the disease, called as the plus disease, include a pupil which does not dilate well, vitreous haze or hemorrhage into the vitreous, and dilated tortuous blood vessels which are seen in the posterior pole of the retina. The presence of plus disease is indicative of an actively progressive phase of the disease, which mandates urgent treatment. With advancing stages of the disease can lead to complete disorganization of the retinal tissue, detaching it from its place, either partially or totally, leading to a blind eye. This can be stopped if it is diagnosed early and appropriately treated with laser or cryo. Retinal laser treatment, which forms the gold standard, helps in halting the progression of the disease and preventing further damage. Avastin or bevacizumab is also being tried in the very severe forms of the disease. The more advanced cases may require vitrectomy surgery, facilities for which are available at only a selected few centers in India. As ROP develops in both eyes simultaneously, if it is not screened and treated on time, this child can become blind forever. As this devastating form of blindness is silent with no external evidence until late, timely screening becomes very important. Any baby who is born prematurely or with a low birth weight should be screened. In the Indian scenario, the current recommendations say that as a rule of thumb, any child who is born before 34 weeks of gestation or weighing less than 2000 grams should be screened within the first month of life. Any child who is born earlier, that is before 30 weeks of gestation or weighing less than 1500 grams, should be screened earlier, preferably within 20 days of life. Unfortunately, ROP affects the sickest of the babies. So even a near-term infant who has sepsis or who develops severe respiratory distress syndrome, who has received multiple blood transfusions, or who's been a part of multiple pregnancies, or is on prolonged oxygen support should be screened. The complete retinal screening should be done with an indirect ophthalmoscope by a retina specialist who has been trained in ROP work. ROP should preferably be screened and treated in the NICU itself, where the resuscitation measures are readily available. What we need to understand and remember is that the child is at risk of developing ROP till the normal retinal development is complete up to the periphery. So even if the initial examination is found to be normal, the regular follow-up is necessary till the complete maturation of the retina. ROP is a lifelong disease. Given that these children have a 30 to 40% increased risk of developing sequelae like refractive errors, squint, cataract, and glaucoma, regular follow-ups should be continued till at least the first year of life. Early action is needed to prevent this permanent and severe form of blindness and its associated tremendous social and economic implications on the families of these babies and the society as a whole. Screen and treat on time. As the treating neonatologist or pediatrician, you can guide the family for timely screening. Let's work together towards vision for our tiny and precious ones. We are glad to introduce the PRAM program, Proactive ROP Screening and Management at NICUs, wherein the screening is done at the NICUs itself with strict adherence to the NICU protocols. Standard ROP examination and management techniques are applied by a trained retinal surgeon.